Nigeria. We were discussing with the director from Kaduna, about people that they have trained, good people. The thing is, the people that leave are those that are actually very good. So people that they have trained in so many things are now leaving to some other countries to go and work because of, anyway, the general problem within the health system. And I think Rael mentioned this frequent transfer of trained staff. I think that's something that we're also facing. And then everybody has been talking about this non-involvement of community stakeholders. This is quite important, especially in northern part of Nigeria. Like in Kaduna State, maybe this is something you might want to talk to Nafisa about. They have a very good established community process within the state, yes. So they have a good community structure where they have people that are representing communities, and it's easy to pass messages, or if you're introducing anything new, there's somebody from the community. So this is something I think that we will look into. Then, of course, everybody has been talking about this inadequate supportive supervision, but you need manpower for this, and definitely you need finances. Most of these places are really far, so for you to send somebody to go for supervision, you need transportation and some other things. So I will have a conclusion slide after this, but before then I'll just show this video of one of our beneficiaries in Oyo State. So as you can see, we are a country that loves singing and dancing. Nigerians, yeah. So we all sing and dance during antenatal and postnatal clinics. So to conclude, the Quality Improvement Program in NCPNC has brought significant benefits to beneficiaries. So the health workers, the women and the babies, and the health system itself. And it has empowered health workers with the knowledge and skills needed to deliver high quality care, to ensure healthier pregnancies and improved outcomes for mothers and babies. So we really want to appreciate the states that we've been working with. They've really been supporting us. And we just hope that we will get the opportunity to continue working with them. And we also thank the Kenya team for organizing such nice activity for us. Thank you very much.
Thank you very much, Awa. So we'll go straight to the presentation from University of Dodoma. Leonard, please.
My name is Leonard Katalambua from the University of Dodoma. I'm going to present the overview of the project implementation in Tanzania mainland, but basically most of the things have been presented, and I would like at the end, I will just speak a few words, and then I will share a video that is showing the project overview implementation, and then we can see what is going on. It actually does not cover all the activities, but most of the activities were covered. So this is the flow of the presentation, and this is how the project is organized. We have the Global Fund and Takeda, but LSTM oversees everything, but we are working with the Ministry of Health and also the local government authority in the implementation of the project. These are just basic statistics that have been shared, but we remember Dr. Mzee is here. They are usually doing the maternal death review, and in 2018 more than 400 deaths were reviewed, and it was seen 80% were due to low healthcare worker competence, poor handling of cases, and a poor provider attitude. These were the main reason for this maternal death. And actually the project is perfectly suited to address these challenges. These are the new statistics that have been presented by Dr. Mzee, and the project goal have been presented again by Professor Charles and Rael, and also how the project is organized have been presented. This is how the project is organized in Tanzania, and we actually enjoy the way it is organized. Having the advisory board at the top is helping us to control each and everything. This is the flow of activities that have been done. We remind ourselves when we were launching the project, where the chief medical officer was the guest of honor in the launching, he highlighted some key issues that are relevant to the project. He talked about most of maternal death in Tanzania occur due to poor quality of care, lack of adequate knowledge and skills among service providers, poor accountability, and the poor practices or behavior of providers. These were the key highlights from the Chief Medical Officer, and actually they are in line with what the project is doing. So we are addressing issues that are pertinent to the government. We reviewed the material because they were shared the material for training, and these are some of the comments that came in the review. Some of the key achievements that we have done, it was the health facility assessment, where almost 50% of healthcare workers were not trained or have never been trained on ANC and PNC. So the project is bridging a gap, and those are some of the statistics. But so far we have already trained 1 healthcare providers on ANC and PNC, and it is a typical blended approach. 30 healthcare workers have been trained on mentorship and coaching, and mentors are expected to reach 150 healthcare providers. But so far we have a challenge. The statistics we have, the current report that we have, only 25 mentees have been mentored by 5 mentors. So this is the challenge of supervision and the follow-up. We are lucky to have the minister responsible for health to donate the equipment that have been provided by the project. We know it is not an easy task having the minister officiating the donation of equipment, and we have the vice chancellor, the one who is closer to the minister, that woman is the minister for health. And I thank Dr. Mzee because he worked, and Dr. Makwani, we worked tirelessly to make sure this happened. These are some of the challenges: delay of funds for implementing activities, and as I have said, the follow-up, budget for follow-up and the supervision. We have opportunity for scale-up. One of the opportunity that the training that have been provided have been recognized by the councils, and now it is recognized as a CPD. People are awarded the CPD points. But also we have translated the material into Swahili. We know in Tanzania we have the challenge of language barrier, especially in English. So we translated the material into Swahili. This is an opportunity. We expect to hand over the translated material to the Ministry of Health as the plan goes. So we expect that the benefits of the project will be achieved. But we have 1 PhD student who is enrolled and sponsored by the project, and is instrumental in this implementation. As a University of Dodoma, there was a Research and Innovation Week. We participated in the Research and Innovation Week. The project was represented, and the good thing that it won among the project in the school. It won based on the amount of fund that the project is having, and it was recognized. And we are available in social media. We are available in Twitter, Instagram, LinkedIn, and we have a number of followers on Facebook. Number of followers you can see. If you follow the page of the Department of Public Health at the University of Dodoma, you will see it is flooded with information from this project. So, and also we have a number of videos that also have been shared that are produced based on the activity. So we'll play the first video. Then it gives us the overview of the project, and then we'll see what has happened. We have a lot of good stories, some that we cannot explain just by words. So it is in Swahili, but it has captions at the bottom. So you'll just follow the caption if you don't understand Swahili. But I know Nafisat knows a little bit.
zinasema kwamba takriban watu milioni 228 waliambukizwa malaria, na kati yao watu 405,000 walipoteza maisha. Tafiti hiyo hiyo inaeleza kwamba kusini mwa jangwa la Sahara takriban kina mama milioni 11 waliambukizwa malaria, hali iliyopelekea kujifungua watoto wenye uzito pungufu, hali ambayo ni hatari kwa afya. Chuo Kikuu cha Dodoma kwa kulitambua na kulipa uzito jambo hili, wamekuja na mradi wa kuboresha huduma jumuishi kwa ajili ya kupambana na magonjwa ya ukimwi, kifua kikuu na malaria kwa kina mama wakati na baada ya kujifungua. Mradi huu unafanywa ikiwa ni utekelezaji baina ya Chuo Kikuu cha Dodoma, Wizara ya Afya na Liverpool School of Tropical Medicine. Na mradi huu utafanywa katika vituo 20 katika halmashauri 8 ndani ya mkoa wa Dodoma. Kati ya vituo hivi 20 zipo hospitali 2, vipo vituo vya afya 8 pamoja na zahanati 10. Utekelezaji wa mradi huu unafanywa kwa miaka miwili, 2022 mpaka 2023. Na katika kuleta ufanisi wa mradi huu, uzinduzi rasmi ulifanywa na aliyekuwa mganga mkuu wa serikali Dr. Aifelo Sichalwe. Alizungumza mengi juu ya mradi huu, lakini hapa anaanza kwa kueleza kila anachokiona yeye kwamba ni tija kubwa hasa kwa wakufunzi na walimu watakaohusika kwenye mradi huu.
Wizara ya Afya ina imani kubwa kwa mpango wa mashirikiano ambayo mmesema hapa utawezesha kuboresha ujuzi wa kufundisha kwa walimu wenyewe humu ndani, lakini na wanafunzi wetu, lakini kujenga uwezo wa kutoa huduma vituoni, hususani wale wapya, na kubadili tabia ya watu wa huduma kwa kutumia vizuri stadi kwa wamepata vioni na bei mafunzo haya ambayo mtaenda kuyatoa. Natamka rasmi kwamba mradi huu wa ushirikiano kati ya UDOM na Liverpool School of Tropical Medicine katika huduma ya uzazi, VVU, ukimwi, kifua kikuu na malaria umezinduliwa leo tarehe 25 mwezi wa 4 katika hoteli ya Afrika Dodoma. Mungu ibariki Afrika, Mungu ibariki Tanzania.
I take this opportunity also to thank the University of Liverpool for this kind of collaboration, because it helped us at the University of Dodoma to deliver our quality service and also to work with the community in improving health facilities, especially in this area of antenatal and postnatal care.
Mradi huu ukikamilika, tunaamini kwamba utatoa matokeo mazuri. Tunashukuru kwamba umeanzia mkoa wa Dodoma, na ukitoa matokeo ambayo ni mazuri zaidi, tunaamini kwamba nao serikali italipokea na kusambaza katika mikoa mingine.
Liverpool School of Tropical Medicine, it's a university. Na sisi kama university tumeweka kipaumbele sana mambo ya research.
Mradi huu umelenga katika eneo ambalo ni muhimu sana na linatiliwa msisitizo sasa hivi kwa baraza na wizara kwa ujumla.
Sisi kwa niaba ya GOTA kama wasimamizi wakuu wa mambo ya uzazi wa mama na mtoto, mradi huu umefika sehemu yake hasa.
Mara tu baada ya zoezi la uzinduzi kukamilika, hakukuwa na kulaza damu. Moja kwa moja likafuata zoezi la mapitio ya mitaala itakayotumika kufundishia.
Leo ni siku ya pili ya kikao kazi cha kupitia miongozo, na ambayo ni siku ya mwisho, miongozo ambayo itatumika katika kufundisha wahudumu wa afya katika kuboresha huduma za mama na mtoto.
At this workshop, the focus is on looking at the proposed tools to be used in the project to implement, to support strengthening of antenatal and postnatal care, and specifically to ensure that all the high impact interventions are being implemented as per universal guidelines as issued by WHO on maternal newborn health quality of care.
Utekelezaji wa mradi huu ulikwenda sanjari na kutembelea vituo vyote 20 vitakavyotumika kwenye mradi huu, na lengo ni kuweza kujionea hali ipoje kabla ya utekelezaji wa mradi wenyewe. Ili kuleta tija kwenye mradi huu, mafunzo kabambe yalitolewa kwa timu ya wataalamu ili waweze kukidhi vigezo. Na mafunzo haya yalianza kutolewa kwa master trainers, yani wakufunzi wa wakufunzi.
We are going to be here for 2 days training master trainers today and tomorrow,
and these master trainers are going to be used to train the healthcare providers.
In this context, in UDOM, we do believe that when the staff can be properly trained to support our mothers, our children, we'll always improve on the outcomes.
Really happy to be a part of the trainer in this master training, because this an objective from this project is to train the healthcare workers. So who will train? That we must have a master trainer specifically from Tanzania.
Mradi huu unafadhiliwa na Global Fund Project, na tunapozungumza hivi sasa, ndugu mtazamaji, mafunzo ya kuboresha huduma jumuishi kwa magonjwa ya ukimwi, kifua kikuu na malaria kwa kina mama wakati na baada ya kujifungua yanaendelea kwa watoa huduma za afya huko ndani. Nitakupitisha angalau kwa uchache uweze kuona hali halisi ya kinachoendelea kwenye mafunzo haya.
Mara nyingi katika vituo vyetu hivi vya zahanati tunatoa huduma za mama na mtoto, lakini mama anapokuja, kitu cha msingi na cha muhimu tunapoviona ni kumpima tu MRT malaria na kumpima HIV na syphilis, lakini tulikuwa tuoni umuhimu sana wa kumscreen TB mama akija ile kwa mara ya kwanza, visit ya kwanza, postnatal care ni kitu cha kawaida tu, namwambia tu mama mtoto ananyonya, mtoto anafanya 1 2 3 4. Kwa hiyo baada ya kupata haya mafunzo, kwa kweli nitabadilika. Tunaomba hata mradi pia, kwa mfano kama hizi hemo kimashine katika vituo vyetu ni changamoto kidogo, kwa watusaidie, watuwezeshe.
Tunashukuru kwa kupewa au kusisitizwa kwa namna ya kuweza kufanya tathmini au kuibua matatizo ya afya ya akili ambayo yanakuwa yanahusiana na kina mama.
Kwa mafunzo haya tumejifunza vitu vingi kwa kweli, kuanzia self learning, Zoom meeting pamoja na e-practice ambayo tumekuja kufanya leo. Kuna issue za violence ambayo imekuwa ni tatizo kubwa sana kwa Tanzania au kwa nchi yetu, maana watu wengi saizi wanajiua, wanapoteza maisha. Kwa kupitia mafunzo haya tumeweza kujifunza namna ya kuwa screen wa mama kwa kutumia maswali 5. Kujua kama huyu mama anaweza anapitia hizi violence, ukatili wa kijinsia na namna ya kuweza kusaidia.
Baada tu ya mafunzo haya kukamilika, utafuata mkutano rasmi wa wadau ambapo watapata nafasi ya kusikia matokeo ya yale yote yaliyotekelezwa na mradi huu na yale ambayo yanafuata kwa utekelezaji zaidi.
So thank you very much. Appreciate University of Dodoma for that really nice video. But we shall be screening the remaining bits during other intervals as we go on with the meeting. So congratulations to the team in Dodoma for a well-executed documentation. And I think it really outputs. Therefore, we hope we can now go to the level where how this is impacting the users of the health services. So I want to hand the microphone to the Dr. Salma Mahmoud from Zanzibar for the presentation. Yes, Salma, you have 10-12 minutes or thereabouts. I hope you can manage.
Good afternoon, everyone. Yeah, I will be sharing the program overview of Zanzibar. Okay, so I will go straight. I will skip some of the slide because my colleague has already presented. These are my outline. So I will skip the demographic data of Zanzibar and I will go straight to the project program and the rest. So the project, as we know, is funded by Global Fund and Takeda in partner with LSTM and collaboration with State University of Zanzibar. Let me go straight to the project background. So the project official was introduced in Ministry of Health and the State University of Zanzibar from January to February 2022, whereby MOU was signed. Then from there, March to May, the integration started, which involved the selecting of the project team member and creating the advisory board, launching of the project. After launching of the project, then we review so that we can come to consensus with the guideline of our Ministry of Health. And then we got ethical clearance to start the project. And from June to July, we started with the assessment. We did the pre-test first from one healthcare facility. Then we did the editing of the tool. Then from there, we selected 10 healthcare facilities, 6 from Unguja, 4 from Pemba, and we ran the baseline survey, which will help us later to see the monitoring and evaluation we did to see the impact of the project. Then from there, we did the blended learning approach. We trained 15 master trainers. So the blended learning approach involves self-directed learning, Zoom, and face-to-face. Then from September, we review the data we collected, and we analyze and we consolidate the report. And then from there, we had a trip to Liverpool where we disseminate our findings. So let us see what we implemented from there and the achievement. So the achievement is capacity building through blended learning, whereby 62 healthcare workers were recruited. Among them, 53 successfully completed the course. Then we did a mentorship training, whereby we mentor 15 mentors from Unguja and Pemba, 20 of them. And then those mentors, they mentee 36 mentees. And the 2 mentors were on maternity leave, so were not able to do the training. Then from there, we improve the infrastructure by distribution of the equipment. Whereby you can see Dr. Ryle with the Honorable Minister of Health. And then we went to the healthcare facility to distribute the equipment. The sustainability of the project is strengthened by the commitment and ownership of the Revolutionary Government of Zanzibar through the Ministry of Health, and their active involvement in the project signify a willingness to continue investing and in supporting maternal and child health services even after the project completion. And we also have an opportunity, the State University of Zanzibar have been granted the opportunity to support 1 PhD scholar through this project. Challenges, majority of the challenge have been reported, but this one is really, I think I have to mention the delay of the fund. Even my colleague have been reported this. And this is the newsletter. Last year, while we disseminating our findings, it was approaching the Mapinduzi. We are celebrating Zanzibar and 59 of the Mapinduzi of Zanzibar. So one of their key milestones is to have better health care for the mother and the children. And this is what we are implementing. So I have a short video and I will play half because it's long, just to see the beneficiary stories from Ministry of Health and the healthcare providers and even the client, the patient. Thank you.
Changamoto kubwa ya vifo vya mama. Mradi huu unamkutana unakuja kugonga moja kwa moja vifo vya mama na mtoto, vile vile waje mtoto kwa miaka 0 mpaka 5. Tuweza kupata mafunzo kwa serikali hili kupatia zana za kufanyia kazi, vituo vya afya visaidika na kupata zana hizi. Vifaa hivi ambazo katika vituo vinne mapema na vituo shida kwa kukabiliana na changamoto ya vifo vya mama na watoto, vile vile kuzaliwa watoto wenye afya bora ambao.
Kwa jina naitwa Fatma Hamisi, ni mkurugenzi mkuu wa nashukuru kupata mafunzo yaliyotolewa na LSTM. Nashukuru vile vile jamii imenufaika kwa mafunzo tuliotoa, sababu tunaweza kufanya kazi kwa ufanisi na kuweza kuwasaidia. Maoni yangu kwamba mradi uendelee au usiuache mkono, kwa sababu tunazidi kupata mafanikio kuweza kusaidia ile jamii. Na pia vile vile katika kukinga ukimwi, kifua kikuu pamoja na TB.
Natumia kituo cha afya huduma na zona nzuri na wafanyakazi wote kabisa. Na kuboresha wapatiwe vifaa vya kimsingi wanavyo kuweza kupata Kwa jina naitwa Umu Saidi Hussein, ni mfanyakazi wa hospitali ya Kivunge, ni muuguzi mkunga, ni wodi ya Makeni. Mafunzo ya LSTM yamenisaidia katika kuongeza ujuzi wangu. Pia vile vile tumeweza kusevu wa mama na watoto wao, tumepunguza idadi ya vifo kwa watoto na kwa mama pia. Vifaa tulivyopata vinatusaidia kutoa huduma kwa jamii. Mimi maoni yangu kwa mradi, naomba huu uendelee ili kwa wengine ambao hawajapata mafunzo na wao waweze kupata ili huduma ziendelee kuboreka zaidi.
Kwa jina naitwa Dr. Bakari Hamisi Ali, ni mmoja katika miongoni mwa wanafunzi waliopata mafunzo ya LSTM katika kupunguza maambukizi ya ukimwi, kifua kikuu na malaria. Tumeweza kusaidia wamama walio wengi katika kuwatibu na kupunguza yale maambukizi kutoka kwa mama kwenda kwa watoto. Shauri kwa huu mradi uendelee kuwafunza na wengine ili kama kuna updates za kila siku tuweze kuzipata kwa wote.
Jina langu ni Bibwa Lisa, natokea Donge Mjini. Kwa kweli huduma hapa ziko vizuri sana. Maoni yangu ajitahidi na kazi, asivunjike moyo kwa kweli.
Kwa jina naitwa Umu Hamisalu, ni muuguzi katika hospitali ya Kivunge katika kitengo hichi cha RCH. Mimi ni miongoni mwa memba walioshiriki katika mafunzo ya blending learning kupitia mradi wa STM pamoja na mafunzo, lakini pia tulipatiwa vifaa vimetusaidia katika huduma zetu. Maoni yangu kuhusiana na mradi, waendelee kutusaidia kwa sababu inatoa faida kwa sisi wana afya, kupunguza haya maradhi, hatimaye tutokomeze kabisa.
Kwa majina naitwa Mwanahamisi Lenguzo, ni muuguzi wa hospitali ya Mwembelaji. Tulijifunza kupitia mambo matatu: kupunguza maambukizi ya virusi vya ukimwi, kupunguza kifua kikuu, pamoja na kumaliza kabisa malaria. Mafunzo hayo yameweza kunijengea uwezo na kuboresha utendaji wa kazi zangu pamoja na kituo kwa jumla. Bado tunafanya nao kazi LSTM pamoja na SUZA, na vifaa wanatupatia vifaa ambavyo vinatusaidia kwenye kufanya huduma zilizo bora.
Jina langu naitwa Mansab Ramazan Mansab, ni mwalimu wa skuli ya afya na sayansi za tiba ya Chuo Kikuu cha Taifa cha Zanzibar, lakini vile vile ni mratibu wa mradi wa huduma shirikishi unaoshirikisha afya ya mama kabla na baada ya kujifungua, huduma ambazo zinahusiana na ukimwi, kifua kikuu na malaria. Mradi huu unatekelezwa kwa pamoja baina ya Chuo Kikuu cha Taifa cha Zanzibar SUZA kwa kushirikiana na Liverpool School of Tropical Medicine. Mradi huu hapa kwetu umesaidia sana, umekwenda sambamba na malengo ya serikali ya kupunguza vifo vya mama na watoto, kwani umewajengea uwezo wa wafanyakazi mbalimbali katika vituo hivyo, pamoja na kutoa vifaa ambapo husaidia kutoa huduma bora kwa kina mama wanaofika kabla na baada ya kujifungua katika hospitali zetu mbalimbali za Unguja na Pemba. Ushauri wangu tu kwamba ni kuwashauri hawa wafanyakazi waliopewa mafunzo haya na wao wasambaze mafunzo haya kwa wafanyakazi wengine, pamoja na kuvitumia vile vifaa ambavyo wamepewa ili kuhakikisha kwamba mama wetu wajawazito wanaofika katika hospitali wanapata huduma bora kila siku.
Okay. Thank you very much, Dr. Salma. And I guess we are learning a few Kiswahili words. I think some people, we might bring a poll soon to just check if you picked any Kiswahili words. Navisat here? Yes. So thank you very much. That was really nice. So we have the last presentation, last but not least, from Togo. I think it will still be done by... Yes, it will be done by Mario.
Thank you. So as previously said, I'm going to talk in French, but all the slides will be in English. Donc je vais vous présenter le projet que nous menons au Togo, une présentation assez brève puisque le programme a déjà été bien expliqué avant. Donc voici le plan de la présentation, une introduction, quelques résultats, les partenariats, les challenges et puis les nouvelles innovations sur le prochain cycle, ainsi que quelques témoignages. Alors le projet, il est financé par le Fonds mondial. Les bénéficiaires principaux, ce sont le ministère de la Santé avec les différentes directions de la santé mère-enfant, direction de la santé de la reproduction, mais aussi les programmes sida, tuberculose et paludisme. Le partenaire principal, c'est l'université de Lomé qui est là en support technique avec un point focal qui est le professeur Keto ici présent. C'est un pôle multidisciplinaire d'excellence. Et puis c'est là où sont les bureaux de notre projet et la gestion financière également. Et puis ça nous permet d'avoir un suivi de l'implémentation, coordination avec le ministère de la Santé. On a une équipe nationale avec Dr Bakusa, Dr Rido, avec M. Ganké qui est ici présent. Et puis, la LSTM vient ici en tant qu'assistant de gestion et assistant technique. Alors, les objectifs du programme, c'est comme précédemment énoncé, c'est d'améliorer la qualité et la disponibilité des soins de santé prénataux et postnataux, avec à long terme l'idée de supporter le renforcement des capacités et du système de santé, et puis avec des livrables qui sont de mettre en place une amélioration de la qualité, un processus d'amélioration de la qualité à travers l'adoption des outils internationaux et des adaptés au contexte national, avec le renforcement des capacités des CPN, CPON, ensuite améliorer la qualité, alors pour l'instant avec des audits basés sur les normes, mais on va voir, ça va changer prochainement. De maintenir un renforcement des capacités et de la soutenabilité du projet, et puis de voir un peu comment mesurer et partager ce qui marche, pourquoi et comment. Alors ça, c'est le résumé des phases précédentes du projet et de la phase à venir. Donc on avait la phase 1, elle a commencé en 2017 au Togo, avec l'évaluation dans 62 formations sanitaires dans 3 des 6 régions, avec l'adaptation des standards internationaux et des outils, avec les partenaires nationaux, puis des workshops, des formations. Et puis c'est lors de la phase 2, donc en 2019-2020, eh bien, qu'il y a la formation des prestataires de santé à commencer. avec la fournition d'équipements en CPN, CPON aux formations sanitaires, la mise en œuvre d'une étude randomisée qui a permis d'évaluer l'efficacité des interventions et quelques recherches opérationnelles également menées. À partir de 2021-2023, donc la phase où on est actuellement, eh bien, on a eu 50 formations sanitaires supplémentaires, ce qui fait qu'il y a désormais 100... Sorry. Donc 112 formations sanitaires désormais, et puis la mise en place des formations, des supervisions formatives et du monitoring avec l'assurance qualité. Et puis la phase 4 à venir, donc à partir de 2024, eh bien, il va y avoir encore 50 formations sanitaires supplémentaires qui vont être incluses. Il va y avoir la nécessité d'harmoniser l'approche d'amélioration de la qualité avec l'approche nationale, et puis l'adoption aussi également de l'apprentissage mixte dans cette nouvelle phase. Alors ça, ce sont les principaux résultats selon les lignes d'action. Donc on a trois principaux axes, trois principaux axes d'action. Donc d'abord, ce qui concerne les CPN et les CPON, on a en tout 18 formateurs, 563 personnels qui sont été formés, avec un taux d'amélioration de 82% au niveau des prestataires de santé et 79% de taux de satisfaction. Il faut savoir que la LSTM et ce projet sont le seul projet au Togo à mettre en place des formations sur place pour les CPN, CPON. Ensuite, concernant l'axe numéro 2, qui est donc l'amélioration de la qualité, donc comme je disais, c'est les audits basés sur les normes, avec 17 facilitateurs de formés, 249 prestataires formés, et puis des réunions d'assurance qualité qui sont organisées. On a 69, donc 62% des formations sanitaires dans lesquelles les audits basés sur les normes sont mis en œuvre. Alors ici, donc c'est ce que je disais, la LSTM est pour l'instant la seule à mettre en place l'audit basé sur les normes, ce qui est un peu problématique pour l'instant au Togo. Donc on va avoir une harmonisation de cette approche avec l'approche nationale très prochainement. Ensuite, on a aussi les supervisions formatives qui sont mises en place dans toutes les formations sanitaires, avec 17 superviseurs qui sont formés et 66 personnels de santé et managers qui sont formés à la collecte et l'agrégation des données de routine. Et enfin, on a un axe de monitoring et donc d'évaluation et de recherche avec donc deux pour l'instant évaluations de base qui ont été menées en 2017 et en 2021 et une nouvelle qui va être menée en 2024. Et puis une étude randomisée qui a été conduite sur plusieurs standards audités, avec une amélioration significative pour trois fonctions principales. Et puis d'autres recherches opérationnelles ont été menées, et enfin dissémination des résultats, puisque sont menées très régulièrement des réunions avec les parties prenantes. Donc, concernant les principales données de monitoring et évaluation, donc là je vous ai juste mis un petit exemple, mais on voit clairement que sur les 50 dernières formations sanitaires qui ont été intégrées au projet, donc par rapport à août 2021, en juin 2023, on a une nette progression des indicateurs, notamment ce qui concerne la tuberculose, puisqu'elle n'était pas testée auparavant et qu'elle l'est désormais dans les structures. Mais je vous propose d'attendre demain pour voir plus de résultats sur ces évaluations de ces indicateurs. Alors concernant les partenariats, il faut savoir que les manuels qui ont été développés par la LSTM, qui servent de support donc à ce projet, sont également en référence nationale pour toutes les formations en CPN, CPON qui sont faites, notamment par exemple par la direction de la santé mère-enfant, mais aussi par la GIZ. Au niveau du monitoring et de la supervision par les parties prenantes, il y a des réunions biannuelles qui sont organisées avec tous les bénéficiaires du programme, le Fonds mondial, les directions, etc. Et bien sûr les formations sanitaires. Les réunions des parties prenantes sont organisées, elles, semestriellement. La GIZ, dans ces zones, utilise le système de formation CPN-CPON qui est mis en place par le projet, donc à savoir les manuels, les master trainers, les kits de formation, etc. Les kits de projet sont également utilisés au niveau des gestions des équipes districts et régions pour leur formation, et aussi pour les écoles de formation de sages-femmes notamment. Et puis, le projet participe à la plateforme SMNIA qui se réunit très régulièrement pour discuter des principales problématiques concernant la santé de la mère et de l'enfant. Alors, le principal challenge de ce projet qu'on a dû faire face, c'est notamment pas assez de fonds qui ont été attribués pour la CPL et CPON pour le projet, et donc finalement moins de personnel de formé que ce qui était prévu par l'action sanitaire. Des audits basés sur les normes, beaucoup de personnel clés ne peuvent plus être formés, notamment les managers qui demandent fortement à être formés sur la qualité des soins. Voilà, donc ça c'est sur le principal problème. La mise en œuvre du monitoring de la supervision qui ne peut pas être faite assez régulièrement, et puis la recherche qui est partie de ce manque de financement. Le principal challenge à venir, c'est bien sûr l'alignement avec l'approche basée sur les dimensions pour l'amélioration de la qualité à la place de l'audit basé sur les normes, et puis un fort turnover au niveau des professionnels de santé. Alors, au niveau du prochain cycle à venir, donc en 2024-2026, on va adapter les formations CPN, CPON à l'amélioration de la qualité, une approche plutôt mixte, notamment pour les professionnels de santé, qui va leur permettre de ne plus se déplacer forcément aussi régulièrement et nous aussi de former plus de personnel. Et puis, on va avoir une formation uniquement en ligne pour une sanitaire au niveau des districts et des régions, et ainsi que pour les travailleurs communautaires. Au niveau des formations initiales, on va avoir une intégration de la qualité dans les formations de sages-femmes notamment et d'infirmières. Et puis, les kits de formation de projet vont être utilisés dans les sessions pratiques. Pour la recherche opérationnelle, une étude coût-efficacité de l'analyse de l'approche mixte sera mise en place en partenariat avec l'Université de Bocconi. Et puis, une étude de faisabilité sur l'accréditation des professionnels de santé va être également menée initiée par l'Université de Lomé. Just try to put the video.
Nous avons implémenté au Togo un outil d'amélioration de la qualité qui s'appelle l'audit basé sur les normes. Nous sommes les seuls à l'avoir amené Et les résultats de cette audit ont montré une amélioration significative des fonctions essentielles de CPN et CPON dans les promotions sanitaires. Nous avons également implémenté à partir du docteur Dankop Bakusa, économiste de la santé, enseignant des universités et aussi le coordonnateur du projet d'amélioration de la qualité des services de CPN, CPON au Togo. Nous formons les prestataires, nous dotons les promotions sanitaires et nous avons implémenté au Togo un outil d'amélioration de la qualité qui s'appelle l'audit basé sur les normes. Nous sommes les seuls à la mettre en œuvre et les résultats de cet audit ont montré une amélioration significative des fonctions essentielles de CPN et CPON dans les promotions sanitaires où nous intervenons. Nous avons également implémenté à partir de cette année les supervisions formatives qui permettent d'aller sur les sites et voir comment les personnes formées améliorent au jour le jour les prestations qu'elles offrent à la table.
Bonjour, je suis docteur Kagosu Abraham AMPP, je suis état de formation, actuellement directeur de la santé de la mère et de l'enfant. Et ma vision pour la santé de la mère et de l'enfant, c'est qu'aucune femme ne nouveau-né ne meurt de cause évitable. C'est pour cela que nous saluons vraiment ce programme de Liverpool, le projet de Liverpool, qui met l'accent sur la CPN et la CPON, qui constitue un défi pour nous, un défi sur deux niveaux. D'abord par rapport à la population, qui traîne pour venir à la consultation prénatale, et tardivement donc, ou qui ne vient pas du tout à la CPON. Et le défi par rapport aux prestataires, c'est que leurs prestations ne sont pas parfois conformes aux directives nationales.
Bonjour à tous, je suis professeur Guillaume Kofibi-Guétor. Je suis le plan focal du projet qui se déroule entre LSTM et l'Université de Lomé au Togo. Alors ce projet a été accepté pour relever un défi, c'est-à-dire réduire la mortalité et la morbidité au Togo qui ont encore des taux élevés. L'Université de Lomé a accompagné ce projet dans son opéralisation. Et l'université également a mis en place une commission scientifique qui a validé les protocoles qui ont été déroulés sur le terrain. Ce que nous pouvons dire également, c'est que ce projet a permis l'amélioration progressive de la qualité des soins de santé au niveau national. Et surtout, les bénéficiaires ont beaucoup apprécié ce projet. Alors, bonjour à tous, je suis
Okay, and I just would like to finish this presentation by some photos that are shared by the supervisor during supportive supervision. They got a WhatsApp group and they can share live their practice and what the issue that they face. So it's very interesting to share the information by that way. So thank you and merci pour votre attention.
Merci beaucoup. Thank you very much, Marianne. That is very nice presentation, and I think the issues are the same. Everywhere when you listen, you see the same picture that is replicated across the different parts of Africa. Whether it's Anglophone or Francophone Africa, the issues are the same, and we are all learning from each other. So we've come to the end of that set of presentations, and we just I want to invite my colleague. Yes, to take us through the question and answer session. I believe people have questions, issues they need to raise, or observations they need to make. All those suggestions are welcome. So, maybe take about 5 minutes or thereabout before we go to the.
Thank you very much. Good afternoon once again, everybody. We have had a series of presentations, and I'm sure we have one or two clarifications and questions that we want to ask, because this is actually a program to learn from each other and to learn from other countries. We need to make one or two clarifications so that we would improve our implementation in our different countries. So I would like to ask, have we documented any questions? Who has any question or clarification we want to ask from all the presentations from the different countries we've had all day? Yes, that would be number one. Number two, okay. Any other question, please? Okay, so you will please introduce yourself and say where you are from, and then ask your question. Thank you.
Hello, everyone. My name is Dr. Lydia Mwanzia from LSTM, Senior Research Associate. My question goes to Nigeria from the presentation that was made by Hawa. I was really interested at the fact that there are about 38 states, and the program chose only Oyo and Kaduna. And, you know, it's like there is an autonomy on the way the healthcare system works in these states. So what informed the choice for Oyo and Kaduna, and in what ways are you able to affect the other states that are not running this program? You know, like here in Kenya, somehow the Ministry of Health is involved, and there is a way it affects policy. So how is it able to affect policy, you know, from the government side?
Yes, thank you for the question, Lydia. Yes, Nigeria is operated, like I said, each state operating independently. So actually the choice of Kaduna and Oyo did not really come from us. This came from Global Fund. And you know, usually is if you have a relationship with a state, or let's say a country, that's where you go. I think they have a good program in Oyo State, the Global Fund, the HIV and TB program. I think yes, it's all through Global Fund. So that was how they selected that. And then at that time, I think the executive secretary of the primary healthcare department in Kaduna is, I think, was somebody in Global Fund. So that's how they were selected. And it's a good choice, you know, because Kaduna State is in the northern part and Oyo State is in the southern part of Nigeria. And when you look at Nigeria, like, you know, I keep on saying that actually people are so different. We were discussing, you know, when I said something about us liking, dancing and all that. So Nafisa was saying in Kaduna State, because of dancing, husbands stopped their wives from coming, you know, for antenatal. Meanwhile, in Oyo State, you cannot come and not dance, you know. So I was referring to what Charles was saying about context and all that. So in like the program affecting other states, I can almost tell you it's impossible. Even within the state, you know, because we are working with like the primary health care, so we get the opportunity of maybe some of the people that were trained transferred to other facilities, so they continue with what we have taught them. So maybe within the state, you might get that, but outside the state, I can tell you that it's almost impossible. It's really difficult to understand how the health system in Nigeria operates. I remember when we were trying to write this paper on ANC-PNC blended learning, they were asking about how much they pay health workers in Nigeria. And I said, I can't tell you that. Because the salary scale in Kaduna State and Oyo State is completely different. And it's different from the federal government. That's when, if you're working in a teaching hospital. So I don't know, maybe we just have to find a way of harmonizing our health system into one. Yeah, thank you.
Thank you.
Okay, good afternoon. I'm Abigail from Viga County, Kenya. I just, from the presentation of Tanzania, I realized there is an issue issuing delivery kits to pregnant women while they go at home. So my question is, remember delivery is a sterile procedure. How do you ensure that these delivery kits are kept safe until delivery? And how are we preventing, because of sepsis, because of other infections that affect the babies and the mothers? How are we trying to prevent that? Then another thing I would like to learn from Tanzania again is the issue of testing, blood sugar testing. Probably at the lowest level, like dispensaries, like the country will have dispensaries, you have health centers, they have higher levels. We understand that is a routine test for antenatal and also a routine test during labor and delivery. And sometimes, how has it made it possible that all facilities are able to do the test, and in which sequence? Probably, is it between 28 some weeks, or is it earlier, or is it routine after every visit? Then, and how is it possible that you can learn from it and disseminate it to even the lowest level, at dispensary level, so that every woman is able to get the test? Thank you.
If you're answering question, if you're answering a question, you look at the camera. I don't know where the camera is.
Asante sana. Yeah, for the delivery kits, these are kept in a bag, which is sealed at the MSD, that is Medical Supplies Department. And as she has said, delivery is a clean procedure. So the contents in the delivery kits, the gloves are sterile gloves. The suture, in case of tears, is packed in a sterile package. Everything in these packages are sterile, except for the cotton wool. The cotton wool is from the factory, and it is packed like that. But most of the things are packed as they are from the factory, and we believe that they are sterile in their packages. So they are kept that way until the woman comes to delivery. And for sugar, blood sugar, we were not checking blood sugar routinely in the past, but now, as we want to adapt the WHO antenatal care guidelines, we have started to implement this intervention of taking blood sugar levels during the antenatal clinic visits. Asante sana.
Thank you. We have another question here.
In English?
Non, il fraîche. Il fraîche. Merci. Donc, je vais parler en français et Marion va nous aider à expliquer la question. En fait, j'ai compris à travers les présentations qu'au niveau du Kenya, il y avait une certaine coordination entre l'approche menée par LSTM, le ministère de la Qualité, et l'approche du ministère de la Santé. Mais pour les autres pays, que ce soit la Tanzanie, le Zanzibar, le Nigeria, par exemple, je n'ai pas perçu ça. Et donc ma question vraiment c'est de voir, qu'on puisse partager avec nous comment ça se passe l'intégration de l'approche LSTM pour l'amélioration de la qualité et l'approche du ministère de la Santé, parce que chez nous, au Togo, actuellement, c'est un débat. C'est vrai qu'on a trouvé une formule d'harmonisation, mais je suis curieux vraiment de comprendre. Merci.
So I'm going to translate. So it notices that in Kenya, there is a coordination between Ministry of Health and LSTM concerning the QI approach, but he was wondering in other countries like Tanzania, Zanzibar, Nigeria, how it works practically, our LSTM approach is integrated with the Ministry of Health approach concerning the quality improvements, and because it is a problem now in Togo that we face, because LSTM approach is really different from a national approach. So I was wondering if there is already an integration of this approach with the Ministry of Health, how it works practically.
Thank you very much. So I guess 3 people will have to answer. We already understand that from Kenya. So we would, in French, what will happen is when each person finishes answering, then she will translate for us. Thank you very much. So Nigeria, which other country? Tanzania and Kenya. Kenya, he said he understood that in Kenya. So let's look at that of Nigeria and let's look at that of Tanzania.
So the program is not coordinated through the federal government. That's what we call it in Nigeria. It's just like I've mentioned before, it's through the states that we work with. And it's usually programs at the federal level don't ever take off. I was discussing with them about the MPDSR. This was introduced in Nigeria in 2015 by the federal government. They brought all the tools. I remember I was trained as a trainer right from 2012 before they introduced and everything, and that's where it stopped. So they will ask the states to do it, but if you don't fund that program, it's not going to happen. Just like the national LSS that is done, the life-saving skills emergency obstetric care at the level of the federal government, it's only done when a funder, somebody is funding that program. So it's not really, I think the federal government, if you ask me, I mean Ministry of Health, I really maybe you would tell us what they are actually doing, because I don't know. Seriously, in Nigeria, it's just the states. So all the programs come through the states. If any big donor wants to come, they select which state they want to go to, and they go. Because if you go to the federal government, it's not likely that your program will take off. I remember when LSTM came, maybe Charles will say a few words about this. He went to the Ministry of Health in Abuja. Everybody is in Abuja, and they said, okay, we need a big meeting to really understand what you're talking about. So we want you to fly all of us to Lagos. Yes, and have it there, and then, you know, you pay per diems and all that. So it's really difficult getting the ministry. I think there is just, I don't know what they're doing. So it's usually at the state level. Yeah.
Thank you very much. Let me just add a voice. Actually, we said it earlier in the presentation that in Nigeria, each state has its own autonomy to decide on how I want to implement my policy. The national policy is there most of the time, but the states will now domesticate to see what suits them, which is actually different from what happens in Kenya. So each state decides, this is how I want to do. Like when LSTM was coming in, they actually paid an advocacy to the state. The state looked at the program and we felt it would be worth the while and it would add value to our process. And we accepted them and we went along. So those are the ways, that's the way that we operate in Nigeria, at least for now. Maybe things can change tomorrow. Let's hear the Tanzania experience. Tanzania.
Yes, in Tanzania we are very lucky. Yes, especially in Tanzania mainland, we are very lucky because Dr. Makwani, who is the director of RCH at the Ministry of Health, he has ever worked with the CHARS in Liverpool, and then the communication started straight away from Liverpool to the ministry. So that's how the project entered the ministry. So even the implementation and everything, that's what we are doing, usually we involve the ministry. We have presented when we were distributing the equipment. Actually, we worked very close to the ministry to get the minister and everything. Actually, all the speech and everything were prepared from the ministry. So it was so easy. And Dr. Makwan now is the chair of the board for this project. So everything that we are doing is directly absorbed in the ministry. Thank you.
To help us interpret to French, do we still have any question? You are okay? All right. Do we still have any other question? I think my work is done here. I will now call on my colleague to come and continue with the process. Thank you very much.
All right, so thank you very much. So I think we've come to the end of that session. So before we go to the last two items of the day, I wish to announce that we have an afternoon break, 10 minutes till maximum 15, so that we reconvene. So you can take a short break and then we come to the final session. Thank you.
Good to see you.
our tea. I'll take you through the process of translation of the material into Swahili language. But I can say we visited some of the health facilities that we are working with, and one of the challenges that was reported was the language barrier. So he proposed that we translate the material into Swahili. The material have been translated, although the work is in progress, and have been uploaded into the WCA platform. If you go to the WCA platform, you will see this picture. You can see start a course. When you click start a course, then you can see the materials in Swahili have been translated. This is the flow of the presentation. The same slides, how the project is organized, but this is a little bit of a background. Language barrier has a potential of lowering effectiveness of any intervention. And Swahili as an official language or media of communication in Tanzania. However, the material that we were using to train these frontline healthcare workers were written in English, and this was seen to be an obstacle. So the project decided to translate the material used to train healthcare workers into Swahili. So how were the material translated? It was a forward and backward translation process. Prior to translation, we adapted the material into Tanzanian context. The two reviews that have been done in many of the countries, so the materials that have been translated are the ones that have been adapted to the Tanzanian context. Then the forward translation and backward translation were done by a team of 4 professional translators. The translation from the original language, that is English, to Swahili was done by 3 members of the first team. So in the team of 4, 3 members of the first team translated the material. Then we had 3 copies of the translated material. The 4th member of the team harmonized the 3 translated material to get one, the harmonized one. And then the 2nd team of 4, again, were given the translated material, the Swahili version, to translate back into English. And the 4th one was harmonizing the tool, the translated material, and then a competent translator evaluated consistency between the original English version and the re-translated English version to see whether the meaning have been maintained. The material that have been translated include the cover page, the pre-test exam, the course instruction, the recorded lectures, the PDF slides, and also the facilitator and participant manuals have been translated. These are some of the pictures on how the materials have been translated. So the translated participant and facilitator together and are available for use. However, we were thinking that we need to have a stakeholders meeting for validation of the material. So the use of this translated together will improve the level of understanding to healthcare providers, and this will hopefully have a positive impact for the improvement of quality of care provided during ANC and the PNC. This is the project team in Tanzania. Thank you so much. I submit.
Thank you very much, Leonard. So now we know that the materials are available in the WCA platform in Kiswahili. And people in Tanzania, in Zanzibar, in DRC, Republic of Kenya, part of Rwanda, Burundi, they can access the information and follow the training. So the next the next 2 presentations will be done by Fiona, and the other one will be done by Lydia. So welcome the development of the ANC policy quality improvement blended learning training package. So the innovation here is converting the face-to-face training to the blended learning model.
Thank you very much. Good afternoon, everybody. My name is Fiona Dickinson, but I'm presenting this afternoon on behalf of myself Lydia and the rest of the QI development team. So we're looking this afternoon at how we developed the the QI blended learning package. So I think we're all quite familiar with the concept of increased coverage plus increased quality equals improved outcomes. And we've heard quite a lot about increases in coverage today. But also we need to bear in mind that whilst increased coverage is good, we also need increased and improved quality. And one of the ways that we have of addressing that is through our quality improvement course, QI course, which has been run for a number of years, and is based on standards-based audit methodology, along with other tools used beside that. So as I said, the course already existed, so what we did was we developed it so that it incorporated a blended learning approach, which has been used with other courses that we run quite successfully, so we felt that it would be a good opportunity to make it more accessible and to make it more cost efficient. And then the approach uses a number of different pedagogic approaches, so we use self-directed learning, we use online group learning using the Zoom platform, and we also use face-to-face workshops. And these allow a degree of flexibility as well as catering for different learning styles. The other advantage is that using the WCEA platform for the self-directed learning means that they're automatically allocated continuing professional development points, so CPD points. So how did we develop the course? As I say, we used the existing QI course as a basis and looked through materials and then allocated the different content to the 3 different learning approaches as appropriate for the content and material. We developed lectures based on that, and these were developed, they were reviewed by the whole team. Where appropriate, they were recorded, so some of them were used as pre-recorded lectures with learning activities interwoven amongst them. Again, they were reviewed and then we piloted them. And the image at the side is, again, from the WCEA platform, so that's an example of what the learning platform looks like. And that's the reflection activity that you can see there. So that the lectures, pre-recorded lectures are interspersed with different learning activities. We also did some online orientations for the previous facilitators, just to make sure that they were comfortable and up to speed with the new course format. And we're also developed a master trainer package, so the new facilitators can be brought on board with a new package as well. So what does the course look like? So the self-directed learning, the SDL part of the course, is in 10 modules. And these, as I say, include pre-recorded lectures, so it's almost like a video lecture, interspersed with learning activities. That might be a reflection, it might be some additional learning, it might be some questions, some reading, something like that. We then have the online group learning, or Zoom learning, and those are live sessions. So it's online, but it's actually a live session with facilitators, a group of learners who will be learning as a group, but also doing breakout rooms within Zoom. These typically last about 2 to 2.5 hours, and then there's 3 sessions. And then there's finally a 1-day face-to-face workshop. So that means that the participants can all be brought together in one location and then have a typical face-to-face workshop with practical sessions as well as lectures. So to support this new approach, we've also developed a participant workbook which has worked examples and templates of the different tools that we use as part of the course. So problem identification, and things like that. We've also developed an e-manual for facilitators. So again, this is a manual, but it's in soft copy format, so that it can be emailed to anybody who needs it, and then they can use it online. They can carry it with them if they so wish. They can print a copy, but the idea is that it can be used as an online resource. And as I said, we've also done the orientation for the facilitators as well. In terms of the orientation, we did 4 orientation sessions, so these were all online, again, to try and familiarise the facilitators with the platforms that we were using, the methods of learning that we were using. And we included 58 participants overall, so 58 facilitators that had been through this initial phase of orientation. Most of them in Kenya, but some from Nigeria as well, as you can see from that. And these were mixed groups as well. This wasn't one nationality, it was mixed groups. So that was good because it meant that because facilitators from the different countries could interact with each other and learn from each other. As part of the development, we've also looked at evaluating the course development using Kirkpatrick levels 1 and 2. So these are looking at participants reacting to the course, and then also the level of learning, so how what they've learned from the course. And as part of the SDL course, the self-directed learning, at the end of that, they do a text, a short test to try and establish a certain level of learning with a pass mark of 70%, which obviously is reasonably high. So in terms of the results, what we found with the so far, and bearing in mind this data is just over 6 weeks worth of data, so this is less than 2 months worth of data. And so far, across the 2 countries, Nigeria and Kenya, we completed, we've trained 251 participants using self-directed learning, 154 from Kenya and 97 from Nigeria. Nigeria started slightly after Kenya for various practical reasons. So I think it's quite an impressive number of people through that phase of the course in say, approximately 6 weeks. And of those, 221 passed the end of the course test, so it's a pass rate of 88%, which again I think is quite impressive. The pass rate could have been higher, but there were a few teething problems initially with the self-directed learning platform, where participants could skip the content and go straight to the test, which then obviously meant that they didn't do the learning test. So once we ironed out teething problems, the pass rates increased. As you can see from the slide, pass rate in Kenya was about 86%, and in Nigeria 91%, because of those practical reasons. In relation to the online group learning and face-to-face learning, 191 participants have taken part in the online group sessions. These are the Zoom sessions, 144 in Kenya and 47 in Nigeria. And then following that, we've had 92 participants who have completed the face-to-face workshops as well. So as you can see, quite a lot has happened in the space of less than 2 months. Tanzania, although obviously it will hopefully soon start with the QI training, has for various practical reasons not been able to start yet, so that's why we're just presenting the data for Kenya and Nigeria. So in terms of the typical participants, as you can see from this, the vast majority of them are nurse midwives. For the self-directed learning, there's approximately 92% reported to be a nurse midwife, and 87% of the online group learning. So this is the same, very much nurse midwives, although we did have some clinical officers as well, and 1 or 2 other graduates. In terms of where they worked, their work setting, again, most were from primary care, so that's the blue quadrant with the colours of which don't show up very well on the screen. So the largest segment And the right-hand diagram is community settings, so the primary care. And then those 54% for self-directed learning, 48% for the online route learning. With the orange, which is the second largest segment, is secondary care, so hospitals, and then the smaller ones are tertiary and other. And then in addition to that, we had 65% who said that they'd had no prior experience of online learning. So this is a new experience for quite a lot of the participants. Because obviously it is a new format of training, particularly for the QI as opposed to some of the other courses that we do, we thought it would be useful to know how the participants were accessing the learning material. So hopefully you can see from the left-hand pie chart, most of them are actually accessing it using a mobile or cell phone, which is a little bit of a surprise, but they obviously seem to be making it work for them. And then the second orange segment, which you can see, is laptop computer. And then there were a few who also reported using a combination of the devices or another device, such as a tablet or a desktop computer. So we need to bear that in mind when we're developing the material, that actually a lot of the participants are likely to be accessing it on quite a small device. So when we asked them how they found the course, we asked them for the feedback at each stage of the course. And 72% of them, on a scale of 1 to 5, with 5 being the easiest and 1 being the hardest, 72% scored it out of a 4 or a 5 out of 5. So either very easy, fairly easy, or very easy to access material. So that was encouraging. But actually, despite the fact that they were using a mobile phone, they were actually able to easily access the material. We asked them as well about where they were when they accessed the material. Were they at home? Were they at work? Was it a combination? And actually, the feedback showed that the split was actually quite even between those two categories. And again, we asked them about the plenary sessions and the breakout sessions. And then again, almost everybody said that they found them either very or fairly useful. So again, that's quite encouraging. And I should say all of the feedback was anonymous, so that they did have the option to be very honest in the feedback. We would have not known who said what. Because it is a new approach to this course, not surprisingly there were some challenges along the way. For some participants, internet access was a challenge. We did provide data for the participants to access the course, but for some, they lived in areas or they worked in areas where internet coverage was an issue, particularly in some of the more rural areas. One of the other challenges that we had was lack of IT literacy among participants. So in order to access the self-directed learning, participants needed a valid email address that the link could be sent to, and there were quite a large number of participants who didn't even have an email address that they could use. So those had to be set up before they could actually start the course. And I think it was, again, as I say, symptomatic of the fact that they weren't particularly literate when it came to sort of using the internet or IT. As I've already said as well, one of the other challenges that some people faced was having to do the course using a phone, a mobile phone. Whilst obviously mobile phones are very useful when it comes to reading large amounts of text or interacting with the group, it's not necessarily the ideal equipment. So for some people that was a bit of a challenge. And then finally, in terms of challenges, we had to try and pitch the course at a level that would be appropriate to a wide range of learning levels or abilities. So the course catered for people who maybe had only finished basic schooling plus maybe a year or two of clinical training, right the way through to doctors maybe who'd done 5 years in university. So it's quite a wide range of educational levels that need to be included within the course. We also did get some qualitative feedback, so we asked participants for any comments or any suggestions that they might have. One participant said we need to have more such training in the near future. I think they actually found it really helpful, they found it useful, and they actually wanted more of this, more similar training. And again, somebody else said it was nice, of course, they got to learn in their own time. I think that's one of the things that quite a few people appreciated, that it gave them the flexibility, particularly the self-directed learning, to actually learn at their own pace and at a time that's suited them. And then another participant said, I would suggest the online training to be on weekends in the future so that it can have 100% attendance with maximum concentration. I mean, this I think is probably more related to individuals. Obviously, what will be convenient for some individuals is not necessarily going to be convenient for all of them, but it's something that we need to bear in mind to target the training, particularly the online group learning, at times that are accessible to individuals. One of the other support activities that we do have is for each of the courses, is a WhatsApp group, so the course have a WhatsApp group for all of the participants so that they can support each other, but also if they have any questions, if there's anything they don't understand, then they can have contact with the course facilitators so that they can gain clarification if it's needed, or if again if you have any problems accessing these areas. So in conclusion, the self-directed learning particularly has had a very high participant pass rate, which is very encouraging. And it has generally been very well received. It does allow the student to have a large number of participants accessing the course in a short amount of time. Obviously, the capacity to do the online group learning and the face-to-face does limit it slightly, but at least they do get that first sessions of the online group that are the self-directed learning in high numbers. I think the course has been shown, along with other courses, similar courses have been shown to be cost efficient, and there's no reason to suggest that the QI course will be any different from that, because you're only having to do one-day workshops as opposed to doing a 4 or 5-day workshop. And as the course, as time goes on, as the course develops, we will continue obviously to develop the materials and improve it. I'd just like to acknowledge, on behalf of myself and Lydia, the whole team. It has been quite a team effort. So from your left, Dr. Uzogiri, the types, it's obviously today, Mohammed, at the back, Alet and Dr. Elizabeth Bruno. And all the rest of the team who helped us with it in all 3 of the countries that we cover. Again, we'd like to acknowledge the funders and support we have from various different organisations across the different countries, and thank you for your time.
Thank you very much, Fiona. So now I will invite Professor for the formal launch of this innovative healthcare worker capacity strengthening training packages. We've had at least 4 of them. So welcome, Professor.
Okay, so probably will not take too much time. We're coming to the end of the day, and thanks to Rael for really managing the time and for bringing us to this point. So let me just say, I think COVID brought with it a lot of lessons in disguise, because that was the first time we started thinking seriously of how to continue healthcare worker capacity building programs in a non-contact way. And then we started thinking about how to sustain a lot of these approaches. When we started, we started with emergency obstetric care courses. At that time, the standard was 2 weeks, 3 weeks, 4 weeks. If you look at the human resource for health shortages in Africa, I have been to the field in some countries where I've gone to primary healthcare centers. They are functional, and it's broad daylight. The door is locked, and the phone number of the healthcare worker is written on the door, and it's written "gone for training." Written "gone for training," and I've been in trainings where you have healthcare workers falling asleep, and I wake them up, what's happening? So we just came from one training, and we've just received another text message to proceed from here to another training. So I think we need some study to find out how many women have died during training. It would be a lot, I think. So I think we need to just sort of think differently. And so what we started with is, we first we developed our advanced obstetric and aesthetic care training package as a blended learning program. Very successful. We have a lot of data around that. And then we developed the ANC-PNC training package. And now, with the ANC-PNC training package, was to now develop it in several other languages. So the first language is Swahili. Watch out, coming next will be French. Now, the advantage of these languages is that they are languages spoken by many countries, regionally in Africa. And then I'll tell you the other advantage. Now, the way we've developed these packages, we've been able to come into an agreement with WCA, so that's the World Continuous Education Alliance, that has arrangements with almost 40 African countries, so regulators for midwifery, medicine, for CPD points. And we are an accredited provider of materials. So we develop these materials and it's put on the platform. And then people from those countries for registration, they are pushed to take some of these courses. So that means that this small pieces of work we're doing, the reach goes well beyond these program countries where we are currently working. We know from our experience, many years working in Africa, it's not easy to change things that have been run for a long time. I mean, if you think about it, so back in the days when we really started fighting the IMOC battle, so you go to a country and you say you want to change IMOC training from 2 weeks to 3 days. First of all the master trainers work in the Ministry of Health, for goodness sake, where do you want to start from? These guys will be in the field, there's DSIP, TM, and you say they should reduce it from 2 weeks to 3 days. Impossible, it's not going to happen. So the only way you change such things is by generating evidence to show like for like, if there's no difference or it's even better. And that's why we have a suite of research, all around, these packages that we've developed. So, excellent job by the team in Tanzania for leading the work on the Swahili translation. So I'm glad that that has come to this stage. And now it will be available. Now, the way these tools have been designed, you can easily build up that local capacity to keep it going. And then only when it is time to bring in some technical help to update materials, that's probably when we come in. But these things have been designed so that they could run by themselves. Now, on the platform, if you wanted to generate data on how people are interacting with it, there are built-in questions. From the back end, you can get all that data, to see how things are going. So this is really looking at a very big sustainable approach. When we start talking about self-directed learning, learning through online and all of that, a lot of people said, it's interesting the different kind of things you hear. Oh no, they will not have mobile phones. Who said so? I think healthcare workers have the biggest and the best mobile phones in Africa. Somehow they have good phones. Then they say, oh no, there's no internet penetration. What are you talking about? There's a famous story of medical air ambulance pilot. So lights a plane that crashed high up somewhere, in East Africa. and they were stuck there. It was Masai who was walking around with his Nokia 3310 that called for backup. So don't tell me there's no internet penetration in Africa. That's nonsense. There's internet. Then you say people are not internet literate. So I've seen people sleeping during events and things and all of that, and I probe, and they tell me, well, I've been on TikTok all night and Instagram and all of that. So, I mean, people on Instagram, Facebook, and you say they do not use the internet, you're joking. So these things are working very well. We just need to explore. And then when you look at the issue of, which we picked up, and we struggle in some countries, when you want people to register, they have to register an email for the first time to log in to get the details. But then it got me thinking. So in many sites these days, they don't bother to make you register afresh all your details. They just say register to social media. You know why? Everybody's on social media. It's easier. You already have one registration. You've already been validated in one site. So you can use that to log in. Somebody else has done all the security check. So we should start thinking out of the box. You don't need to have people register all their details again if they're already validated somewhere. So this is something to think about. And then, you saw from, the data that Fiona shared, a lot of the people we worked with, they were working in primary care, so primary care rural area. So you would argue that these are the people who will have the lowest IT literacy rates, lowest internet penetration, but that was not the case, based on their feedback. So this sort of worked very well. And it was interesting to see in terms of convenience, where were they accessing this? Half of them at home, half of them at work. And one of the qualitative feedback said, I just like it, I can learn at my own time, which is brilliant, because, at the time you feel you can learn best, you can sit down and engage with the material, which is beautiful. Now, in some of the countries, when we try to organize the sort of webinars online, it's just a discussion with that group, which time works best for you. It shouldn't be the time that works best for me sitting in the UK. You know what I mean? I just give them 8 to 10 o'clock. That's when we're going to do it. But if they tell me 2 to 4, that's when we finish our clinic. That's when there's less traffic. That's when to do it. So we just need to be flexible because we need to think about what are we aiming for. We want them to learn. So if you want them to learn under duress, learning is not going to take place. So I think the advantage that we've had is that we've used a lot of evidence-based learning techniques and pedagogy, which we've put into a lot of these materials we've developed. So I'm really happy to launch, the next 2 packages. I think over the next year we are looking at, bringing out some of these materials in French and doing some work on our basic emergency obstetric care package. So I'm really grateful to the funders for this opportunity to do this piece of work. Did I say 4 packages? We actually have one more, the Midwifery Educator CPD program, which you'll hear about tomorrow. So that is partly online as well. Now, a big problem with all of these packages is whereas we have them online through an accredited site, they are available to all healthcare workers. I would like to see a situation where these are by some law, really directed to those people who need it. So, for example, why should somebody who is working in, medical records or in orthopedics take a training course in maternity? It doesn't make any sense. But if you have everybody who works in maternity compulsory, you have to take the emergency obstetric course every 2 years, then that makes sense. You're really directing that. So I think we need to find a way to close the loop. I think that's where there's still a problem. So a policy aspect to all of this. So I just want to thank all the teams for the great work and great collaboration. I know I pushed you very hard to meet deadlines. But I think it's a beautiful project and I think you should all be proud of it. So it gives me great pleasure to launch these 2 packages and I hope that it's not just for LSTM, it's for everybody, all the partners. And as you interact with them, if you find any mistakes or whatever, please reach out to us. Medical material or methods of learning and all, they're not fixed. It's not for life. It keeps on evolving. So we learn, we improve, and we hope that we can impact positively on the lives of women and their newborn. Thank you.
Yes. So thank you very much, Professor. So the packages are now raised and they are available, and we can all encourage our healthcare workers in the different places to engage with the materials. Before we close the day, we have a short video clip that we need to just show for a few minutes, and then we'll conclude the day.
Improving the quality and availability of HIV/TB and malaria services into the routine antenatal and postnatal care services.
Through this collaboration, the university is benefiting in terms of capacity building, and we need more collaboration of this kind that can build capacity in terms of the staff, but facilitate, but also enable the university to engage with the community in health delivery in this area of health delivery services. We are going to be here for 2 days training master trainers today and tomorrow, and these master trainers are going to be used to train the healthcare providers that will follow on Wednesday and Thursday. After that, the Kenyan team is also going to work hand in hand with now the trained facilitators here in University of Dodoma, and then we are going to proceed to Zanzibar, where again we shall work in the same structure, train master trainers there, who are also now going to be used to train the healthcare providers.
Ce projet visant à relever un certain nombre de défis, il est fort que la mortalité maternelle, néonatale et infantile reste élevée. Nous formons les prestataires, nous dotons les formations sanitaires en équipement. Nous avons implémenté au Togo un outil d'amélioration de la qualité qui s'appelle l'audit basé sur les normes. Nous sommes les seuls à la mettre en œuvre et le résultat de cet audit a montré une amélioration significative des fonctions essentielles de CPN et CPN dans les formations sanitaires où nous intervenons. I learned a lot from the Liverpool
International School of Tropical Medicine. I was opportune to be trained under quality improvement with them, then ALCPAC. But that mentorship, it took me somewhere I've never been before. I learned a lot. I had 6 mentees under me, some are from my facility and the other one from other facility. Currently, we are discussing antepartum hemorrhage, antepartum hemorrhage, and mentees in my facility. While in the other facility, we have minor discomfort in pregnancy. That is what we are discussing with them. The mentorship really helps all of us, both me and mentees. In fact, even those that are not among the mentees, because they join us during the conversation yesterday. There are different causes of antepartum hemorrhage. Some cannot diagnose, but with this mentorship, it helps us a lot. Most of the mentees, we can diagnose what is the cause of antepartum, what is the cause of the antepartum hemorrhage, and we can treat it accordingly. They refer when the canal limits. The mentor becomes around to create, to give us knowledge concerning mentorship and some kind of skills that we've not been doing in PSC data. We've improved, we are doing them now, such like respectful maternity care to pregnant mothers. Each through that knowledge of mentorship, pregnant mothers, they are happy. And we also, the mentee, we are also happy with the da mazo sun karbe mu cikin kulawa da ƙoƙarin zuwa na farko da mazo mun suka karbe mu aka yi test ɗin hawan jini, aka yi min malaria, aka yi min test ɗin fitsari da kuma alhamdulillah lafiya lau babu wani matsala gaskiya. Gaskiya na zo asibitin nan, na zo awo wannan asibitin karo na biyu kenan, amma saboda farko da na zo sun kula da ni sun min awon BP, sun min awon hawan jini, sun min awon fitsari, sun karɓe ni hannu biyu, sun kula da mu. Awon ciki ma muka je aka gwada aka mana awo, kuma ga shi yau an kuma min awon jini, an kuma min test ɗin fitsari, an kuma min awon BP. An awon ciki na je na karɓi magani kuma da a test ɗin malaria za su karɓe ta hannu biyu su kula da su ba wulaƙanci. Na yi awa a asibiti kusan da dama haka amma gaskiya na ji daɗin wannan awon asibitin da na zo. Saboda ina zaune aka ce min in gwada nan in gani sai na zo na gani kuma na ga kulawa da tarba mai kyau ta mahimmanci. Ina zuwa awon ciki. Yanzu ana kulawa da mu, ana yawan magunguna da allurai, na ga zuwa haihuwa, ga haihuwa suna kulawa da mu sosai. Mutum ya haihu lafiya, allurai da magunguna duk suna bayar alhamdulillah. Wasu ga wannan asibitin abin da za mu ce sai dai godiya. Suna kulawa da mutane sosai. Gaskiya muna jin daɗi suna yawan kulawa sosai da sosai. Ba abin da za mu ce sai dai mu ce Allah ya albarka.
All right, thank you very much, Meshach, for that video clip. I think it summarizes the many things that we've said since morning. As we come to the end of the day, I think the key messages, we all get the message that there is so much that is undone. The project is making a big contribution, but we still must keep pushing on because there are still many things that we need to sort out if the MMR is really going to come down in the next few years. So as a team, I think we go on with the conversations tomorrow. We also need to engage on the social media platforms because so much information has been put there through the handles of LSTM Kenya and the units in the UK. So if you get time to go to X, please follow us retweet, like, and the like, and even, you can also repost in your own Twitter space. So I think I just want to appreciate all of you for the time taken. Day one is normally not easy, but for your patience and, commitment and focus, we really appreciate the engagement. Now we will dismiss the meeting. But before we go, we will ask the LSTM teams, Kenya and UK, and colleagues from Tanzania to remain behind for a short meeting. So I think I want to ask one of our colleagues to pray for us so that we can disperse. Any volunteer, Onesimus? I wish to volunteer you. Yeah. Thank you. We'll see you tomorrow. We have another briefing today, so we hope to see you here at 8:30. Oh, sorry, and tomorrow we are going to a different room. Is it Duma? We're going to Simba. Simba is the street, so we will be in a bigger room because we will have additional participants. Thank you and see you tomorrow.